Welcome to the Yoga Therapy Hour podcast with Amy Wheeler. I've had the good fortune to travel the world learning about yoga therapy on a global scale. And I've been able to meet many of the leaders in the field along the way. I want to share with you what I'm learning as I interview our colleagues from around the world. My hope is that together we can reduce suffering of all sentient beings through our work as yoga teachers and yoga therapists. Hi, the International Association of Yoga Therapists is sponsoring this episode of the Yoga Therapy Hour with Amy Wheeler. And that's going to give me a chance to tell you a little bit about the upcoming conference called the Symposium on Yoga Research. This is a conference that the International Association of Yoga Therapists puts on every fall, and it's usually held in person at Kripalu, which is always a special conference because you get to go to the East Coast and see all the beautiful trees in the fall. However, this year, the conference is online because of COVID. And so it will take place November 15th and 16th. And it is a phenomenal conference for all yoga therapists to go to. It is our job as yoga therapists to understand the most recent research in the field of yoga therapy. And that's going to help us do a better job with our clients. But even more importantly, it is the research that we can bring to allied healthcare providers, to allopathic medical doctors, to naturopaths, to psychologists. We can take what we learn at this conference and actually bring it to them and say, here's the latest and the best research. And that's phenomenal because the I-AYT team vets all the research that's presented, from the posters to the main sessions to the pre-conference workshops. They vet it and make sure that it's really good research so that when we present it to our colleagues, we actually know that we can stand behind what it is that we're showing them about why and how yoga works for healing. So if you'd like to join us at the conference this year, again, it's online. One of the really beautiful things is that you will have those replays for 1 year afterwards. So if you miss parts of the conference, you can still jump in and see those for 1 year afterwards. Or if you miss the conference completely, let's say you're listening to this podcast episode a few months from now, you could still purchase the pass for the conference and get those replays for 1 year after the conference. There is a student discount. So if you are a student, it would be $135 for the main conference. And if you wanted to do the pre-conference workshop, it'd be another $30. So it'd be $165 total for both the pre-conference and the main conference. If you are already a professional in the field, the main conference is $225. And if you wanted to add in the pre-conference workshops, they are $275 for that total package. Now, the really cool thing is that this can be used as continuing education. And all of us who are C-IAYTs, we need continuing education units. So the pre-conference is 4 units, the main conference is 8 units. That would be 12 total if you did both. So I really hope that you will go to www.iayt.org/SYR. And I'll say that again, www.iayt.org/SYR, and check out all the presenters. We have some really great ones this year. And also there's a BIPOC discount, and there's a discount for people who live in countries that are identified by the World Bank as lower to middle income. So check with IAYT about those discounts, and we're so happy that we're going to get to see you there. Thank you for joining us today as I interview Kelli Bethel, who has had a 3 decades long career in yoga therapy. She specializes in yoga for stroke, as well as traumatic brain injury, which has a lot of overlap with stroke. And she's also a specialist in working with yoga therapy for cancer. So Dr. Bethel owns Tafiya Yoga and Wellness. And I want to show you her Facebook page because she said that Tafiya Yoga and Wellness is the best way to reach her through Facebook. And it's basically Tafiya, I asked her, means journey in an African culture that her husband was familiar with. And so if you want to reach her through Tafiya Wellness and yoga, you can do that. But she is also the director of yoga therapy and experiential learning at Maryland University of Integrative Health, MUIH, the only master's degree in yoga therapy right now. And basically what that means is she runs the clinic at MUIH. So when people get done with their yoga therapy training, then they can go into the clinic and actually work with real clients. So I am really excited to show you this podcast because Kelly took us from start to finish, which I wasn't even planning, but it worked out really well. She basically tells us how it is that she chose to be a specialist in the area of stroke and traumatic brain injury. And she also loves cancer, but that was kind of a separate little conversation that we started with. But once we got into stroke and traumatic brain injury, she told us how it is that she gets her gigs. How does she get hooked up with hospitals and get in the door? And that in itself could have been a great podcast. Then she goes into how does she negotiate her fees and how it is that she wants to work with that hospital. And each hospital that she works for does something very, very differently than the others. It's one hospital maybe want to hire her as a contractor. Another one wants her to run her business, Tafiya Yoga and Wellness, out of that hospital. Some of them want to collect the money. Some of them don't. Some of them want her to market. Sometimes they're going to do the marketing. So I think that in and of itself is a really good thing to think about for us yoga therapists. She also talked about different niches, different areas that the hospital is now able to fill for themselves. Like, what do people do when they're released from physical therapy? They've had a stroke, but they're really not ready to go out into the world yet. They're not super functional. What is that gap? What is that need? And how can she fill it? And I think this is the key that we need to all be thinking about, is finding those gaps in the healthcare system and then figuring out how to fill those gaps and meet the needs. She talked a lot about the language we have to use with healthcare providers and even with the clients, really being specific about use this language for stroke, but not that language. It's not a stroke victim, right? It is a person who's had a stroke. And how important language is. She talks about how important having the research to back up what we're talking about. And specifically, it can't just be general yoga research. We need to start thinking about yoga therapy research and really designing the studies around yoga therapy and getting specific about what it is that we're doing and how that's yoga therapy, not to discredit yoga in any way, just to be more specific about what it is that we're doing and why someone might want to hire a yoga therapist. That's going to help everybody in the field. She discussed a number of studies that she's kind of engaged in and the importance of evidence-based medicine for what we do. Then she goes into specifically, what is it that she does with people who have strokes, right? What are the primary things? And one of the biggest things that I learned from her a couple of years ago that she's really big on is this idea of balance and gait and really figuring out how to take people who can't get out of a chair up into the world where they're safe. What she really also taught us in this episode is how to keep people safe, even on Zoom. You know, telehealth is the future of yoga therapy. There's no doubt about it. It's going to be a wonderful way for us to deliver it in COVID times. But she's also saying, how are you going to keep people safe? So when she's in a regular classroom, the ratio of teacher to student for yoga therapy is about 1:5. One teacher to 5 students max, because she can't get around and help everybody and keep everybody safe. On Zoom, she can have a few more people in the Zoom room, assuming that they meet the standard, the minimum standard to take a Zoom class, which is, can you get it up and down out of your chair by yourself? If you can't do that, there's certain classes that she cannot teach yoga for stroke with on telemedicine or Zoom. Even in those classes, she still has safety precautions, and she lists a bunch of them, which were really cool to hear about. And she has a helper where one of them is demonstrating the poses and the other one is looking at the screen to make sure students are safe and they're okay. And I asked her, how do you pay a helper? And sometimes the hospital will pay that person. Sometimes it'll be more of a practicum or an internship. And sometimes she'll charge the hospital enough that she can basically pay that person out of her salary. And again, going back to evidence-based medicine, to show the hospital for stroke and TBI, you have to have a smaller ratio to keep people safe. And the evidence is out there for that. So I just think this is such a wonderful interview. For me, it really tapped into so many things that we talk about in our year-long Optimal State business course that starts every May, because so many yoga teachers and yoga therapists do not want to specialize in a particular area or two. I always tell people you can choose one and then expand out, but you have to choose and go for it. Because one of the things she talked about that was so amazing is if you don't choose an area and specialize, you're still working with the whole person, right? Even if you specialize in traumatic brain injury, you're still working with the whole person. You still need a yoga therapy kind of comprehensive program. But if you don't specialize, you don't understand the needs of those people specifically. What are their special things that they need? But also all the surrounding stakeholders, like the hospital administration. What do they want for their traumatic brain injury people or their stroke people, right? What benefits are having these classes meeting for the hospital? So we can't, as we teach in our business course, we can't just go and be a general yoga therapist. If she had said to people, I can do this, I can do that, I can do pregnancy, or I can do stroke, they would have never hired her. They want a specialist in stroke. That's what they're looking for. And so it was really a fun conversation for me, both from a yoga therapy perspective, to kind of talk about how did she develop these really amazing stroke programs, and then what does she do with the clients, and how has she adapted to COVID with stroke patients online, but also from an overall business standpoint, whether you want to work in a hospital or you want to be an adjunct where you kind of go in and fill a niche that isn't being offered at the hospital with your own business. How do you get in the door? What kind of language do you need to use? All of it from a business perspective was really solid advice. And I thank Kelly for working all of that in there, because I think that's a primary need. And so I hope you enjoy this episode as much as I do. Welcome, Kelly. I'm so happy to have you here this morning. And I know that you're on your way out the doors. Tell us where you're going this morning after this podcast.
Yeah, so I'm actually really excited. I'm headed to Baltimore. I currently live in Scranton, Pennsylvania. We relocated here, for those who know me, from Maryland in January of 2021, for my husband took a new position. And so I'm headed to Baltimore for the Society of Integrative Oncology International Conference. It's being held in Baltimore this year. And as I know we're talking about stroke today, but oncology is another area that I work in. And SIO is the acronym for Society of Integrative Oncology, has a very strong yoga special interest group. We are starting, as many people know, we have a lot of research in cancer and yoga, and we're actually at a point now where we can start developing best practices and educational guidelines for yoga therapists and yoga teachers. So it's a very vibrant group and a very active group. And so we're super excited about that. SIO and I-AYT are working together on that venture. And so I'm headed to the conference. I'll be teaching 2 wellness classes Saturday and Sunday morning. And we've got some great yoga therapists presenting. One in particular is how to keep our clients and patients safe during cancer. So I'm super excited to hear their presentation this weekend. So that's where I'm going.
Well, let's just take a tiny little detour. I know we're talking about stroke and maybe a little bit of traumatic brain injury today, but I think this area of cancer is one of the areas that yoga therapy is actually thriving and maybe our door in to integrative medicine, to hospitals. Tell us a little bit about how you see that, because it seems like the area of cancer is ahead of many other areas already.
Yeah, and I think there's a couple of reasons for that. I would say that both oncology and the VA are probably the two biggest sectors that I see hiring yoga therapists. And I know there's a group in the VA that's working, and they have a group that's developing SOAP notes and stuff. I think part of it is we have the research now.
Mm-hmm.
We have the research that shows, yoga is beneficial for fatigue. It's a category 1 recommendation. And when you start having those recommendations, those category 1 recommendations, that's when healthcare providers go, wait a second, we're missing something here. The other thing too is that, and we actually have a scoping review starting at MUIH. We're getting ready to actually start doing the data research, looking at yoga therapy in the research, because we haven't done ourselves any favors in the yoga research because we label everything as yoga. And a lot of what we do when we start working with special populations, stroke is another one that we see it in. We call everything yoga, or we don't identify it as yoga when really it's yoga therapy. So we know in cancer, yoga is a category 1 recommendation for breast cancer fatigue. We have other recommendations for yoga, but then we also know breath work and meditation are beneficial to people undergoing cancer or anywhere along the cancer continuum, really. The cancer is a continuum. We are missing a lot of, as yoga therapists, we do a lot of stuff that's not being called yoga therapy. And so, so it's also important. So we still need to educate, but because we now have the research and because we're at a point where we can start creating best practices and to, start developing, the additional training requirements to work in oncology, because there are a lot of it's beyond that of just a C-IAYT. You can't, an entry-level C-IAYT needs more training in oncology care. We're at a point where we can start doing that. And I think that helps get us in the door with oncology, because we actually have the evidence in the US. And again, it varies from country to country. And I know that from lecturing, outside of the US, but in the US, that helps get our foot in the door because we have evidence to support that what we do works.
And I think it's so important to point that out, that we are not doing ourselves any favors by not identifying it as yoga therapy, because then the healthcare provider thinks, why do I need yoga therapy instead of yoga? I can pay a yoga teacher $25 and you want me to pay a yoga therapist, $75. Why should I do that? The research says yoga is fine, when really the research may be essentially yoga therapy.
And I think it's important too, as we start developing these standards, is that there are a set of standards for yoga therapists who need more education. And then there's yoga teachers who need more education. And so our goal, and we're just at the infancy, we're going to start with best practices. And then we'll focus probably on breast cancer research first, because that has the most research. That's where we're headed. We should be starting sometime this fall on this work. But they're not, it's not just the yoga therapists that need more education, it's the yoga teachers as well. And so, if you're a yoga therapist who hasn't been trained, but you have a yoga teacher who has extensive training, they're not, you still got to go through some more training as a C-IAYT.
It's so tough. I'm doing a study at Wake Forest with Stephanie Soul. I think it's been 4 or 5 years working on a breast cancer study. And some of our teachers are yoga teachers, but they've had extensive training in yoga for cancer, right? Mm-hmm. And then we might have a yoga therapist come in, which is supposedly a higher level of training, but they've never dealt with cancer, right? And so I think even in writing up the research studies, we need to describe what is the expertise of the teachers, what is the level that you need to achieve the results that we achieved in this study.
Yeah, and I think that's really important. That's one of the conversations as we've started to work on this scoping review for yoga therapy, the term yoga therapy in literature, is that once we finish with this, then it will open up, it's kind of that foundation, right? We know what we don't have, what we have or don't have, and I suspect it's what we don't have in the literature. Then we can also start looking at, okay, so what do we need? We can't go into healthcare and say, I'm a yoga therapist, when everything in research is saying, yeah, but it only says yoga.
Right.
And even the term yoga is not systematically defined well in the literature. When I wrote the introduction for the protocol, because we registered the protocol and I gave it to someone to read, they're like, I don't agree with your definition. I was like, that's the whole point. Like, depending whose interpretation, depending on where you find your definition, are you finding it on the internet? Are you looking at ancient texts? Depending on who translated the ancient text, it's still going to look a little different. And so, that was just writing the introduction for that was really hard, because we, trying to find there is not an operational definition of yoga. And that's hard in research.
Yeah. We're studying this thing that we can't even agree on the definition of it.
Yeah. And it's funny because I even looked at Yoga Alliance, and Yoga Alliance does not have a standardized definition of yoga. Yoga Australia, has a very nice definition, and that is.
You remember what it was in Yoga Australia?
I don't off the top of my head, but
I'll look it up.
But that was a real, and I'll give my shout out to Yoga Australia. They had a really nice delineation on Yoga Australia had a really nice delineation of yoga and yoga therapy on their site. So it was also nice to see, I think, and I'm probably getting on my soapbox now, but I hate how we've parceled out yoga therapy. When you look at Yoga Australia and you see what a nice job they've done of saying, we're all working on a similar,
right.
We're different. One's not better than the other. And I was pulling some stuff together about what is yoga therapy for our students who started their new trimester that are new to yoga therapy. And I love that article that you guys wrote. And I love that graphic with yoga, the circle with yoga in the middle, and then yoga therapy down below that you guys created. Like, I was like,
I'm going to pull that up right now on our screen.
I love that. Yeah. Like I love that. Like, that to me. And I just wish we could get to that in the US, where we're all under an umbrella, rather than, no, you can't use that term. So that's my soapbox.
Yeah. So the article came out in the Yoga Therapy Today, and it's called Shared Foundations for Practice, the Language of Yoga Therapy by Dr. Ananda Bali Yogi Bhavani, Marlisa Sullivan, Matthew Taylor, and Amy Wheeler. And, I don't know, I guess I can't see how long ago this was, summer 2019, right?
Yeah, a little bit ago.
Yeah. And it really goes into what are the similarities of yoga and yoga therapy? What are the differences? And then, what's yogapathy? What's yoga therapy? So it's a very nice reference piece. And I think especially, like you said, Kelly, if we are looking to educate doctors and nurses, and here's what we do, and here's why it's different.
Yeah, and I think it's really important. And I think the nice thing about that too, the language that is in that article is in that common language. I think when you work in healthcare, you have to talk their talk to be able to call their attention. And so, I think so. That's the other piece that's in there. You have some really nice languaging that goes between healthcare and yoga therapy.
So before we get into stroke, I promise we're getting there. How long do you think this is going to take to really firmly be established in healthcare? Because we're just doing the research. I know this study I've been working on at Wake Forest, it's a $500,000 study, and we've been doing it for 5 years now. And this is one study. Like, how long could this take, do you think, to really be firmly established in healthcare?
That's a really good question. And I don't necessarily know if I have the answer. I mean, I think C-IAYT is doing the steps necessary to really give us the foundation, and for those who don't follow along, we've created the organization, we've developed what we do, we have scope of practice and standards. And now we're working on an exam that's going into beta testing this fall. And so, I think that's the first step. I know the licensure versus non-licensure is highly contested and highly debated. And again, I can only speak to the US. I think the more evidence we have, the better. I do think we need to be very clear, like we were talking about, what is yoga therapy and what is yoga in what we're doing. And I think part of the problem too that I see is people are doing research that aren't really yoga teachers or yoga therapists, but they've gotten a grant or they've seen something. And so they're not clear on what they're doing. And so, I think that doesn't necessarily help us. But I think the first thing is, I think languaging is really important. What are we doing? Are we doing yoga? Are we doing yoga therapy? One of the hallmarks for me when people are like, oh, because I work in groups with the stroke and we'll talk about that. And they're like, oh, well, you're doing a yoga class. I was like, no, it's yoga therapy. They're assessed. Like assessment is to me, that is the easiest fundamental way are you assessing the clients.
So let's go into that. Let's go to stroke now. Yeah. And I don't know how much traumatic brain injury is similar or different, but how do you assess someone who's had a stroke from the yoga therapy lens?
I think, again, it's going through all 5 koshas. So I think, and it goes back to the similar conversation around cancer. You have to have an understanding of that biophysical, medical, you have to have an understanding of stroke from that framework, because while it doesn't, everyone wants a cookbook, everyone wants to be like, oh, 12 weeks out, we do this, this, and this. That's not true. You still, to me, yoga therapy is an art and a science, right? You have to do that assessment. Part of that assessment is understanding the medical. You can't just be like, oh, I'm a yoga therapist, I don't need to know that. I just need to know the koshas. But you got to know what's contraindicated and not contraindicated. It informs your practice. It doesn't dictate your practice. So I think you look at all the koshas, and I think stroke, especially because I tend to work post-rehab. So I have work at area hospitals in Maryland that's post-rehab. So most of my clients have just either, and I'll take anyone regardless of when they've had their stroke, but I get people fresh out of rehab and they're moving back into the community. And that is really where you can work on those koshas, meaning and purpose. What gives you joy? How do we get you back connected, in your community? And I think those are really big things. We still address physical, the physical piece, strength, range of motion, breath, but really you can really work some of those other koshas that rehab doesn't, and not because they're not interested in them, but that's not what their goals are necessarily.
I think that's so important. I wrote down on a sheet of paper, I wish I could find it, but I wrote down yesterday, the art and science of well-being. I think that's what yoga therapy is, art and science of well-being, because like you said, they're going to have a physical therapist to help them with their gait. And that's not that we don't do anything with yoga postures, but they have a specialty person in that area. They're going to have maybe a respiratory therapist or a speech therapist. That's going to be paid for through their post-rehab care. What we offer that's a little bit different is, like you said, the meaning and purpose, the joy, the how am I going to find my way through this new life? And those are kind of spiritual concepts.
And people always ask, I think as a PT, because I've worked for decades as a PT and I love my profession, I help people return to function. That's kind of my goal. So with yoga therapy, I help people return to their lives, and it may be a new life. And so when we work with someone post-rehab, they so badly want to be back to the way they were. They want to be back to normal. And for a lot of them, this is their new normal, similar to what we're going through in COVID, but this is the new normal. And so how do we help them reconnect, or maybe not connect, depending, if there was something that wasn't great in their past that they don't, but how do we reconnect them to their purpose? How do we help them find meaning and joy when you can't move your arm and you were the person who took care of your grandkids? We've had discussions, and some days in yoga therapy, you may not get to an asana or breath practice or a meditation because where your client shows up is they need to talk, and so, we've had issues where people were the primary caregivers. One of my stroke groups was very young, or is younger, and they were all primary caregivers or the primary breadwinner in the family, and now they can't work anymore. They're disabled. And so that's a loss of insurance. There's a lot of guilt. If you had taken a year, 6 months in the hospital and rehab and then outpatient, you feel very guilty about, I don't want to say they all do, but many of my clients will express that they feel guilty that their family has to take off to take them to their doctor's appointment because they're not cleared to drive and may not ever be cleared to drive. So there's a lot of processing, and a lot of my clients will work with psychology outside of our classes. And they then take what we do in yoga and like, look what I learned. And so then the psychologist pulls it in with them as well. So we have a space in stroke rehab that is different than OT, PT, psychology, their medical physician, their neurologist, we have a space to really help them return into society and into their communities.
And I think we as yoga therapists, because we do the work, we understand what that space is. But I think it's hard for PTs, OTs, psychologists, respiratory therapists, speech therapists to understand, well, what are you doing that's different? Why do they need you too?
Right.
So what would you say to that?
So it's nice. Inpatient, my clients always say, I wish I had this in the hospital. And I always laugh because a lot of what I might be doing would probably be what the PT was doing, but they didn't realize it, that, if the PT, when they were sitting them up and the client was having anxiety, because if you can imagine, all of a sudden you can't move half your body and they want you to sit over the edge of the bed and you're like falling to the side and you're at risk for falling on the floor. And, you can't, it's a miserable feeling to be, to not be able to use half your body. And so being able to do something like a simple breath practice, right, that taps into that parasympathetic system just to kind of calm could go a long way. I am finding that some of the younger generation, I do some research with Emory, they have an understanding of yoga. They don't understand how it works, but they've we just started a new semester with the Emory students that we're doing research with. We asked them to write why they wanted to be in this research project. We're doing a scope and review on Parkinson's, and they all have experience as yoga. And while they don't understand what it does, like how the mechanisms work, they do understand what it does for their bodies in terms of creating a relaxation response, making them less stressed. They're interested in starting to bring that into their practices. So I do think some of the younger generation has more experience. I think that we also, and I don't know how your university is, but I know when I was at the University of Maryland, self-care has become a big topic. How do we start creating resiliency in these students and helping them succeed in these? University of Maryland, has PT, OT, nurse, or not OT, has PT, nursing, medical students. How do we start creating resiliency in them so that they can take that into the field and be successful in their health careers and not have burnout? So I think they are coming in a little bit more with a more integrative approach. I do think we're also starting to see the trends in healthcare where we're looking at the whole person, and and back to the research. I'm a big research person. I can't be a PT without having that as a, what's the research show you? We know meaning and purpose is important, right? We know that is having meaning and purpose has longer longevity regardless of your comorbidities. So I think people are starting to realize that. I think, in oncology, we see that, like, people who are supposed to have days last years because they have meaning and purpose and have something that they want to, can finish. So I think that we're starting to see those trends as well.
And, you and I worked on some committees together at the International Association of Yoga Therapists. And the big discussion was, if all these professions start taking, okay, we'll do a little breath work and let's add a little meaning and purpose, it could feel to some like the field of yoga therapy is just kind of getting pieced apart and taken into all these other fields. And then we don't need no yoga therapy anymore. But I think what you have told me, I'd be interested to see if you still feel this way, because that was a few years ago, is that it's through those pieces that we'll actually get in the door of healthcare. They'll start accepting us and understanding us. And then they'll want, hopefully, real yoga therapists, that's their specialty. And by then we'll have our national exam and maybe move towards licensing, So do you still feel that way, that by sharing all of this, it's actually getting us in the door and they're not piecing us apart and they're not our competitors?
Yeah, I do. And I think too, we also do some of what PT and OT do, right? If we're working on gait and balance, I don't have a strong mental health background, but I'm sure there are people in the mental health community that would say, yeah, we are doing some of it. I think, first off, I think it's always good when a team works together as a team. And so I think when you can teach something like a breath practice and then have the PT reinforce that in their training, because it becomes functional, right? If you're having anxiety and you can stop for a second and catch your breath and really kind of regain your focus and tap into a place where you're a little more relaxed, that parasympathetic response, if the PT can carry that over, then it becomes a functional skill, right? It's not just something we do on the yoga mat, which is really what we want, right? We want people to take stuff off the mat and be able to apply it in their day-to-day life. So I think, I laugh because my husband's a physician and he'll refer me people and he's like, I'm not quite sure what she does, but I know she can help you.
Well, and I think, isn't that part of the problem, that it's hard to clearly explain what we do. I think we're almost like a quilt where we stitch all the other stuff together. You've got the PT and the OT and the speech therapist, and we're like stitching together and holding space and being there and reinforcing what they're doing and working as a team.
Yeah.
We are the stitching, I think.
Yeah, I mean, I think we are. And I think when you have someone on staff, and I know there's a couple yoga therapists that are, one in particular who works at the Shepherd Center, who I know is a recreational therapist. And the PTs and the OTs have her come into the gym. They will actually facilitate the movement, like help maintain balance or maintain a good sitting posture while she does something like a breath practice or a mindfulness practice. So, once they get the idea of what you can offer and how it's different, I think that's important. But, and I think seeing it, being, again, part of the team, like what can I bring? And I always, again, for right now, I think in American healthcare, in the US system, we have to go back to the evidence. And so, and luckily when I first started doing the stroke work, and I wrote a protocol for one of the hospitals, I had 4 papers to pull from. And the biggest one was a 4-person case study, and now we have systematic reviews, and we have the research to show that yoga is beneficial. And yoga therapy is beneficial. I should probably change my own verbiage if I'm advocating for correct verbiage in the literature. We didn't have that before. So those are all really important things to do. I've been very lucky in my work, both in my oncology work, because as a PT, people are like, oh, well, you just bill. I don't bill. I've been cash-based since I started working in integrative medicine. I'm very lucky. My stroke work goes through stroke services, and it is provided through community outreach through Joint Commission. So my programs go through Joint Commission review. But in the US, you have to provide community outreach at a cost or a loss. So that is how my programs have been paid for. Depending on location, I work in 2 different hospital systems. One is a more affluent area, and so the hospital has provided scholarship for those who can't afford. One is in a more blue collar area, so the hospital underwrites majority of the cost of the program. The cost is very minimal to the clients, and then they pay me. So, and they do all the marketing and the advertising and the registration, which I love.
Was it personal relationship, or how? I think a lot of people want to know, like, how do you get a position like that?
Honestly, I'd like to say that it's the universe put the person in front of me. I think it's very, very important. And I know, Amy, you're a big business person. You have to have your elevator pitch. I happened to be somewhere having lunch, and someone said, oh, let me introduce you to the new director of stroke services at this hospital. And she said, what do you do? And I said, well, I'm a PT, but I really want to start using yoga for the neuro population. My entire career has been in neuro, adult, and pediatric. And so I said, I just think it's got tremendous benefit, and I really want to start doing that. And she's like, great, I need a program, and I don't want to do a stroke support group. I want something with movement. Can you write me a protocol and let's meet? And that was it. In the other hospital, I happened to be having lunch, and the director of community outreach came up to me and said, I hear you run a program at another hospital. Would you be interested in doing one down here? And I mean, so that's really how it's been. It goes back to having a clear business model of what you want to do. And I have no background. Like I've learned the hard way through the years about business, but I cannot underscore how important it is to have an elevator pitch and very clear on what you can do and be able to speak it. And for me, talking neuro is very easy because that's what I had done my entire PT career. Talking yoga, and stroke was, I had to make sure that I had done my research. I knew what studies were out there. I knew, and again, we're talking, this is like 2006. So we didn't even have some of the techs that we have now. So some of the mechanisms weren't there, but I had enough that I could do an elevator pitch. And so that's how it started.
Well, and I am so thrilled to hear you say this because, I run this yoga for business course once a year. And the hardest thing for the students is to actually decide what is their niche, who do they want to work with. They all just want to be general yoga teachers. And if you, at that moment, when they came up to you and said, hey, what do you do? Or if you've been like, oh, I teach general yoga. I can do pregnancy. I can do this. I can do that. I used to do this, but I'm kind of wanting that. You're not getting hired.
No, not, especially not in these specialties, especially not in these chronic conditions,
right,
where there's a medical piece to it that if you don't know what you're doing, you could seriously injure someone.
Right.
Yeah. And it goes back
just a call out to everybody out there. Stop. If you want to be a yoga therapist, try not to be a generalist. I mean, yoga therapists are generalists, but really get clear about here's what I want to do with my life when I grow up, and be able to state it very succinctly like you did.
And it can change over time. I mean, when I started this, I did oncology as a PT when I first graduated PT school. And I was like, okay. And I hadn't really touched it in a while. And then when I started when I moved over to the University of Maryland, I was asked if I could start doing some oncology. And I was like, yes, I need more training, but yeah, I'm willing to take it. And I will say, I love there is a branch of oncology that's neuro-oncology. So that's brain tumors and those type. And so that really is the mixture of both my neuro work and my oncology work. And so I do love neuro-oncology. So it wasn't that far of a reach for me to do what I was doing. And the place where they asked me to step in did a lot of brain tumors. So I was, very much at home in that element. But I think it is really important to have clarity around what you can do and to be able to do it and to be able to say it succinctly. And I know it sounds cliche, but you really need to practice that elevator pitch, because if it can't flow out of your mouth when someone asks you like the ABCs and 1, 2, 3s, then you're not going to get it, because it really was divine intervention. I mean, it was, right place, right time, and the universe set the person in front of me. I gave a lecture a couple of years ago at one of the CICs, and my title was Eat Lunch in the Hospital Cafeteria and Other Things I've Learned, but I think everyone wants to, march to the front door and say, here are my papers, I'm a yoga therapist, hire me. And it doesn't work that way. Like, there really is, you have to have an understanding, and this is kind of off topic, but you have to understanding of what you can bring to the institution. And depending on who your stakeholders are, you really have to you really have to know who you're presenting to, because the administrator, while I have no doubt that as a yoga therapist, you're going to do a great job, they want to know how you're saving them money or how you're meeting a need for them as a hospital or a healthcare system or, an organization. And so for me, it wasn't that I was going to make these incredible changes in their patients. It was, I was meeting their Joint Commission need, and I was bringing clients back into the hospital system, which is what they wanted. They wanted clients coming on campus to see all the other things that they had to offer. And so, that was important. I've worked my brain tumor was actually through marketing. They had free integrative medicine services, and it was a marketing, and it was something that their competitor, 30 minutes away didn't have. And that's what they tracked. I mean, this
is so key, Kelly, because we are naive as yoga teachers and yoga therapists, and we think it's all about the clients. It's not. It could be about marketing. It could be about saving money. It could, like you said, be about getting people in the door. We have to go. And I just told one of my students this, who has an appointment with the hospital. Don't talk, just go listen. Go say, what are your needs? Like, spend the whole time getting them to tell you what they want. And then you can decide if that's something you want to meet. But like you said, everybody wants to walk in the door and be like, hey, hire me, and that's just not how it is.
No, it's not. And I think just like we assess a client, we have to assess a situation, right? And and when you look at developing a program, you have to know what each stakeholder is. What can you bring to the administration? What can you bring to maybe the physicians or to the PT or rehab? I mean, for stroke work, physical therapists love to have someplace to discharge someone to, right? They really don't like sending them out into the abyss. So for my stroke guys, they can send them to me and know that I'm going to be that next step out into the community and helping them reintegrate in the community. Because we do have a problem in stroke work where they have special needs and they can't just step into a gym or a yoga studio and start practicing, because oftentimes they actually have a physical limitation or there's contraindications and they could, seriously get hurt. So, I fill a niche for the hospital. I fill a niche for the PTs who refer to me. I fill a niche for the neurologists who don't know what to do with someone who's 4 years stroke and they want to do something, but they can't, they need a little more expertise, but they don't really need PT. So that's really important. You really need to assess. You have to identify who your stakeholders are, and you have to know what their needs are and how you can meet them, and then be able to say how you can meet them. So putting in, I'm a big, put it in bullet points, put it in writing. In cancer, one of the studies that we didn't get a chance to run before I left university was that we wanted to look, and so if anyone wants to take this up, I do recommend it. Clients who are happier, or patients who are feeling good and feeling happier, have less visits to the physician. So it'd be a very interesting study to look at. And I would start with breast cancer, or I would stick to one type of cancer, not just breast cancer, but I would pick a cancer to stick with. I wouldn't, because it's a lot of variables. But look at, can you do an intervention and track how many times they go back to the physician's office? That right there is a huge savings. If the client is doing well and the patient's doing well and feeling better and not constantly going back to the physician, that's what an administration wants to see. So I think we just like our patients, when we get into these situations, we have to assess the full situation, and really you develop a plan of care, you develop a protocol, and how.
And if you can't even choose your niche, there's no way to understand the needs of the stakeholders in that niche.
No, you can't, because you can't even tell them what you can do. I think I always tell people, if there's an area that you really like, that you're skilled in, like for me, neuro was a no-brainer because I could talk around neuro fairly easily without problems. If you've worked in another field and you really like that niche, but you want to bring yoga therapy, start there.
Yeah.
For me, if I had started with oncology, it would have been a lot harder because I hadn't been working in that area in a long time. I still needed more training, even with all my years of training. I still had to go do more oncology training before I felt comfortable working in that area. But I think if you're a new yoga therapist and you haven't had any experience in a particular area, that's going to be a little more challenging than starting with something that you know pretty well.
And you just basically outlined that for stroke. What do the PTs want? What do the administrators want? What do the clients themselves want, right? But there's these gaps in healthcare that we can go in and be like, hey, we can do that. We can be the bridge between you've been discharged from your PT, but you're not really ready to go to the gym full on yet. That's an area of need. And, I live on a little mountain, and we have some PT/yoga people that are doing just that. They're doing the PT at the hospital. So they have full-time jobs, but they've opened a therapeutic fitness center as their side business, these two ladies. And so the people can be discharged from the hospital where they were working with them. And hey, we've got this gym over here where we're going to help transition you. That is a brilliant idea, right?
Yeah. Well, and I think it is a gap. And I will tell you honestly, it is an identified gap between healthcare and return to the community, especially around stroke. I see it in oncology too, especially neuro-oncology, because if they have long-standing, physical disability, cognitive issues, they may have them forever. And so they need a safe place that they can go and be part of a community. And also we know that from a physical standpoint, that cardiovascular fitness is huge in stroke, and that the risk of having, one of the things we need to do is prevent a secondary stroke. It's 33% risk that you will have another stroke. So we have to help our clients reduce their risk factors, and physical activity is a hallmark of that. But you can't just go to the local Y, because no one there knows how to how do you adapt the bike if you don't have a hand grip? You do need training. And I think PTs have stayed in their niche, speaking of niches, and trainers and yoga teachers and yoga therapists have stayed in their niche, but there's got to be some cross training, back to what we were talking about before, because if you don't know how to work with someone that is hemiparetic, they're not going to be successful, right? We want our clients we need to work in their capabilities.
I think we've just established a really amazing opportunity for yoga therapists that I really hadn't thought about before, opening kind of a gym/yoga therapy center. Yeah. And it could even be one big room with different types of weights or some treadmills and a yoga space, and I know a lot of yoga people are also kind of fitness people, and then connecting with PTs and hospitals and saying, hey, I've got this center that here's exactly what we do. Can we go into, Kelli, like for stroke, what are the things that yoga therapists need to, you just mentioned a couple like the grip, but what are the things that you're going to see as a yoga therapist that you would really need to know about stroke?
Yeah, I think the first thing is you have to have a kind of an understanding. There are some contraindications. So we typically, and again, I'm generalizing, but we typically don't do inversions. So bridge is probably about the most inversion. I don't let my clients drop their head below the heart. One of the other things, and this has always been a highly controversial thing, and I've talked with other physicians and neurologists around there, I don't let them turn their necks in poses. So anything that's a twist. We don't know what people's carotids are. They could be stenosed. We don't know. And you run the risk. And I know that they turn their head to drive and things like that, but I don't need them to do it they're doing it enough in their life. I don't need them to do it in yoga. And I've talked to a couple of physicians because I've gotten pushback when I've taught stroke classes before that, oh, well, why are you doing that? I was like, well, we worry that if they could pick off a plaque, we worry that they're occluding. And so I stick to that. They can have limited mobility. So they might have part of their body that doesn't work. They do have, come with braces and they need to use those. They may or may not get their full return. What they have is maybe their new normal. A couple of things. One is having an understanding of what caused their stroke in the first place. So was it blood pressure? Was it stenosis? Not everyone knows, but having an understanding is important. We avoid breath retentions and those type things. I'm kind of jumping all over the place and kind of running through my checklist. Things like diabetes, if they're diabetic, we have them wear their shoes and standing, which I would do with any diabetic anyway. It's really having, and then knowing how to move that hemiparetic limb, knowing how, balance is a huge issue, transfers can be issues. So there is a lot in the physical. We also run into language deficits like aphasia. So you have to teach differently. Aphasia is not a cognitive issue, it's a language issue. And so they lose the ability to go right and left. They don't know their right from their left. So often I will teach, like, we're going to turn towards the bookcase. We're going to turn towards the window, use the arm closest to the bookcase. We do a lot of multisensory learning. So like I demo, we, in some cases may have to touch like arm, like they don't know what their arm is when you have depending on the type of aphasia, like arm, sometimes I may have to do a physical assist to like, just very gently like help. And they're like, oh, okay, I got it. So there's a lot that goes into working with them. The other thing, I like working in a group because depression is a huge issue. Depression and social isolation is a huge issue with stroke survivors. And so working in a group allows us to create that informal social support network that is so critical because I can tell them the best way to do something as a PT, but I'm not walking their walk. So when someone's walking their walk can actually say to them, no, this is what I found, this is what's helped me, then they hear that. And we've had, back to your point about having a safe, a kind of a therapeutic studio space. One of the things that I've learned is I have clients who started with me 15 years ago, and are still with me. Like they've tried to step into the studio. Maybe they've tried another program, and because it just didn't work for them. And so they can come and practice yoga, and we're still working on goals and things, but it's a place where they can be successful and safe and find the benefits of yoga. And I would argue my one program is a pretty advanced yoga. When we started doing this and we would start, I don't teach in Sanskrit because my clients often have language issues. So I make it a point. And so when we talk about the niyamas and the yamas, I would talk about it more in a I kept it kind of vanilla. And over time, they're like, no, we want to know more about it. Like, we really want to know about the yamas and niyamas. We really want, one group wanted to start journaling as a group. And so we put together like journal prompts. I run in sessions so I can staff it. We run on a 1-to-3, 1-to-5 teacher student ratio. That is the recommended, number that came out of Canada, one of the Canadian studies for small groups for neuro. So that tends to be what we work with. Everything is modified. And so you can walk in a class and everyone's, if we're doing Warrior One and I have 6 clients, there may be 6 versions of Warrior one of whom is just separating the feet, standing wide, and someone else might be in a relative full, what you would consider a full version of the pose. So
can I show a picture? You came and taught for our yoga therapy program a couple of years ago online, and this is one of the pictures from your presentation that, this woman is doing tree pose, but you've got someone next to her in a walker that has just shifted his weight to the right. His left foot isn't even off the floor, right?
Yep. And what you don't see, you can kind of see my assistant in the back, the gentleman with the cane is doing tree, and she's actually giving him some proprioceptive input into his hips to help him maintain his balance. And then the gentleman sitting is actually taking it and sitting. So I mean, this is one of my classes. I still work with a few of these guys. A couple of them have moved on. And we do, that's 5 people with 5 different versions of the pose. So, group classes are a workout.
Right.
All my staff is trained, we have worked together for years. I have learned the hard way that I'm getting ready to mentor someone new. And before I even begin the mentoring process, I actually make them come and just observe, because I've learned the hard way when I start mentoring and start, training someone, that they get into it and they're like, this is not what I thought it was. This is harder. Or, often sometimes people will see them as victims. If, again, back to words matter, they're stroke survivors. They're we have to use first person. They're a person who sustained a stroke. They're not stroke victims. They will argue that. I will also say, one of the reasons I started teaching, one of the reasons I actually went and got my DPT so that I could teach at a university level, was because one of my clients, who was a pediatrician, pulled me aside and said, Kelly, you've got to get more people doing this. Like, this has been so helpful and life-changing. And we need more people who are trained, to work with stroke survivors successfully. And so you've got to, you really have to train, you need to do more training. And I was like, well, that's really hard right now. But, I keep reminding myself when I'm like, I'm not doing as much in the clinic as I was, because I'm, really teaching full time now and running the student clinic. And I can't, but I know that if I don't, I'm better getting 20 teachers trained than I am seeing 20 clients, because those 20 people then can do. So the more that I can train, that then can help start training other people, the more clients that'll be served, because there's the stroke, the number of stroke, and I don't know where it falls now in terms of, but it's definitely one of the top 5. It was the leading cause of disability. I don't know if COVID will take that over at some point, but it was the leading cause of preventable disability in the U.S.
So can I go back to, you having an assistant in the ratio 1-5? Does the hospital also pay for a second person to be in there? Because I think that would be a tough sell. Or is that part of the training? So the second person is kind of volunteering so they can learn this.
I've done it both ways. I've done it as people who want mentoring, that want to learn, and my one person now has been mentoring with me, and because I have a business, so I'm at a point now that I would consider paying her. And she's like, no, she's like, I want the mentoring. She's like, I'm not there yet. And I was like, okay, like, you let me know when you are. The one hospital system that has the most that I have we've had up to 15 clients in a space, but we typically run around 12, because of how I'm paid and they're paid. I hire them. So my business has a contract with the hospital. And so that's the hospital that has the scholarship. So the clients pay for the sessions. That all comes to me, and then I pay my therapists and teachers based on that. So it's not a hard sell when it's a safety issue.
Right. I think what you're describing is so interesting too, the different ways that you have negotiated with these hospitals.
Yeah,
that sometimes, and that, I think laying that out for people as you just did, that sometimes we do it this way or this way. And I've been talking to my business students about that. Go in and ask them, do you have a model? And if not, could I suggest one? Like, they're pretty open if it makes sense financially. And like you said, they're not looking to make a ton of money. If they break even, they're fine.
Yeah, they have to break even or lose money. So the one hospital that's more in a more affluent area, they donate the space. So it's an in-kind donation of space and then scholarship for those who can't pay. They also do all the marketing and advertising, like, which is big because it's in a magazine. It shows up on Facebook and things like that. The other hospital, when I wanted to meet with them, said, no, we're going to contract with you. We want to take care of the waiver. We want to handle the registration, which I'm like, knock yourself out.
Like, yes.
You're going to take care of the money. I'm all for it. And then they just pay me. And then, right. Like I said, the person I have now there is mentoring, but at some point I would expect to pay her.
Right. And how is all this going with COVID? I mean, I saw a picture of you working at MUIH with a big mask and
yeah. So at MUIH, we are back in person. Our clinic's back in person. We are in the clinic. The yoga therapist and the clinic faculty are face shielded and masked.
Can I show the picture?
Yes.
It was a little shocking to me, honestly, to think about being a yoga therapist. Oops, did that work? Yeah.
I look like Big Bird.
Oh my goodness. I guess for me, I would almost rather teach online than have to wear like a biohazard suit.
But you know what? So first off, that mask is actually, the face shield is really nice. It flips up. So I only have to be covered like that. So I'm teaching anatomy and physical assessment. And so when we're in physical assessment, we're actually in the face shield. But when I'm just teaching and not really in close proximity, then I'm just in a face mask. At first, I thought it was going to be really daunting. I will say, another big shout out to MUIH's IT department, because at the last minute, someone said, "Oh, they probably need microphones." And so most of you all don't know me, but if you know me, you know that I'm not the quietest person. I'm usually the one at MUIH or when I'm teaching that they like, "Could you talk a little lower, please?" But even I needed a microphone. So they had a great setup for us. And honestly, once I got going and once the students got going, it was fine. Like you totally forgot you had it on. Like at one point I'm like walking around and realized I still had the face shield on, not even realizing it. But it was so nice to be back into like, and I'm a big person, when it comes to touch, like I'm always like, you need, as someone who's licensed to touch, when we touch someone, we're impacting their nervous system. We're giving them proprioception, even if it's just very gentle and we're not, doing anything. So I'm always like, make sure you need to touch, like know why you're actually touching, because you're affecting the person, and not even getting into the discussion of trauma, you're affecting the nervous system. So, but I have to say it was so nice to be back in person. It's a little energy. Like I was glad to have a 4-hour quiet ride home after 2 days, because it was the first time I'd been with that many people teaching, but it was nice. I think it's just, sadly, I think COVID's not going away anytime soon. And so there's benefits to both. I will tell you, we've kept the stroke program going, and what I did for virtual, because one of the things, as we all know, going back to the research, we don't have a lot of studies, even in the medical world, about the efficacy of
telehealth. Yeah.
So we have these like evidence-based fall prevention programs, which working in stroke, I'm a big, I talk a lot about falls, because I feel like, because we're working, especially my group works I'm working in the community, you have to have an understanding of fall prevention and falls. And so I talk a lot about that, and even in my classes, we do a lot of things to make sure that we have good mobility in the feet, the ankles. My clients in general, everyone usually wants, one of their goals is usually to improve their balance. Like that's a big thing, because they don't want to fall. So when we went virtual, it was like, okay, what are we doing? And I had one group, and again, in 2 different groups, 2 different things. My one group was like, I'm not doing Zoom. I don't want Zoom. My other group was like, let's try Zoom. We'll be fine. So we did one group with Zoom. The other group, went through just Facebook, tried Facebook Live. That didn't work. Finally, I was like, look, if you guys, we're going to have to go through Zoom or we're not. And so, but the issue became safety. Like, how do we, because we know these guys, a lot of my clients have mobility issues and safety is key. We know from having them in class that, we're using the wall. I have a great prop and I didn't pull it out. I should have pulled it out, but I'm a big fan of the ballet bars, the portable ballet bars, because I can put them over everyone's mat and they're weighted down. And that way, instead of trying to get everyone to the wall, when you have everyone with mobility issues, getting someone, up to getting 6 people against the wall who can't all walk, it's like, there's your class, right?
45 minutes later, you got them at the wall.
Class to get to the wall for tree pose or for mountain pose. So I love these balance bars, but it's like, how are we going to do this? And so I will say one of the best things that I've seen since COVID, going back to where we started some of this conversation, is the sharing. Like, so, as institutions and as organizations, we're starting to like, okay, we're going to try this. Here's what we've learned. One of the biggest ones was Winston-Salem University was doing, there's several fall prevention programs that are standardized. Only one of them has shown efficacy to be virtual. So and I can't remember off the top of my head which one it was, but so they had 350, I think they had 350 registrants, and they're in rural, and the PT students were going out, or it's a rural area. So they were like, and so then, same questions we all had. What if they don't have a computer? What if they have spotty internet? Like, how are we serving those who are underserved? How are we not, alienating people that don't have internet access? So they went first. And so nothing was published, but they agreed to have a webinar, and they presented their results. And so from that, I took their thing. So one of the biggest things was they did not let anyone who couldn't get in and out of a chair independently stand and do the protocol. Those people went into a different batch. And I was like, that's it. Like, if they can't stand independently, they can't get up and they can't do the standing poses. So I'll have to take them in sitting. Is it what I wanted? No, because we need to address balance. And if you've seen me speak in person, I'm a big thing about these clients. If you want to improve balance, we actually have to train them in balance. Sitting in the chair doing strength of range of motion is not going to improve their balance. Studies show there isn't carryover from being stronger necessarily improves your balance. So I'm a big proponent of that, but that was going to be out at least temporarily. But they needed community. Some of these people had not left their house. So I was like, look, so what we did with the one group who was that meets twice a week is one day was a chair class. I was like, everyone can do the chair class. And then we had to tell a couple of people who, believe me, were more than like, I get it, that they couldn't do the Friday class because there was going to be standing involved. And that's how we split it up. My other group, everyone can stand, and I know them very well. And they all can get in and out of the chair very well. And actually a couple of them get on and off the floor amazingly well, probably better than I do some days. So that group, we stand. But I mean, the other thing is, again, we still have at least 2 people on the call, because we're virtual. The one program is supposed to go back in person. They're kind of like, debating it now. My other group is virtual, but expected to go back in the winter. The only reason we didn't is because they're actually, the hospital, get this, is building a yoga and meditation space for the entire hospital system. So we're going to be in there. We're temporarily without a space. So that's why we're virtual. But, that was how we did it. And that's how we've been doing it. When we're on the board, and I'm sure like many of us who have been teaching virtually, I have a large monitor that I'm looking at. So One of the reasons I don't recommend doing more than 8, because then the pictures get too big. So I can see them. And then what we do is my assistant will she might teach that day and I watch the boards, or I teach and she watches the board. So there's always 2 persons on the call. Other safety things that I'm sure you've talked about and other people talk about, knowing their cell phone number. And I'll tell you a funny story in a minute. Knowing where their address is, because there have been issues, knock on wood. Someone had an issue that Matt Taylor came and did risk management for the special interest group for oncology. And someone shared that someone got ill and fainted on the call. What do you do? Right. So you got to know where you have to have their address. What happened to me is my client, who can get on and off the floor very well, there was background noise. The phone kept ringing. So I muted him. Well, he fell asleep in Shavasana. So Oh yeah. So we're like, Bob, not moving. Bob. Finally, my assistant's texting me. She's like, I'm starting to get worried. She's like, I need it. What's, and all of a sudden, like his thumbs came up and he had fallen asleep. But like it probably took 5 seconds. It felt like 3 hours because I was like, oh my God, something happened. Like, like let me find my emergency contact number so that I can call him. But he had fallen asleep. So now I'm trying very hard not to mute people so that I can hear them. And he was like, I was saying I'm okay. I'm just resting, but because I had muted him, I couldn't hear him. So we've learned a few things, but that's how we've handled COVID.
I just think listening to you, it's so clear that you are willing to respond to the needs of the moment and switch. And okay, now we're doing this. And the flexibility and adaptability is key to your success, I think.
But isn't that what we're supposed to do as yoga therapists? We're meeting the client, we're meeting the situation at where it is. We can do all the planning in the world. And I will say stroke has taught me this, because if anyone who knew me like back in PT school, and I'm still an organized person, I lived and died by my planner. This is at 8:00, 9:00, whatever, and when I met my husband, who is a surgeon and does a lot of trauma, I learned, you can't plan like that. Like you just kind of go and be ready to go off the cuff. So I've gotten better. I'm still kind of organized, but I think, even in stroke has taught me that too. Like my clients are big Ravens and Orioles fans. And if the Ravens have the late night game playing someone in California and it ends at 2 a.m., you pretty much should just chalk up your day to either restorative or yoga nidra, because they're going to be so tired from staying up till 2 a.m. to watch the Ravens play that Monday morning yoga is going to have to be really gentle, probably has no standing. Because a lot of my clients have abnormal muscle tone, cold, heat, fatigue affect them. But and again, that also shows up every time they come in. So if they're really upset about something, or they're really, something personal is going on, you're going to have to revamp what you had planned to do that day, because they come in and all of a sudden their arms pulled up, their shoulders pulled up, and something else is going on, and you got to stop. But as yoga therapists, I think we have to walk our walk.
Absolutely. I love that. Just being in the moment, being present with what is in this moment, and not going off that predetermined protocol or script.
And I think we've all seen it when we've worked with students. Sometimes we get so pigeonholed into, this is what I want to accomplish today, that I always joke. I'm like, the client could be on the floor in cardiac arrest and you wouldn't know, because you're going through your script and making sure you've done this, this, and this. And you're not even seeing what's in front of you, because that's what you had planned that day. I have a big iPad, and people are like, oh, you did. And I was like, I sometimes do, because I kind of have an idea of what I want to, accomplish that thing. But I have every class I've ever put together, because sometimes, like, if you have a meditation that you really like and you need it that day, like to be able to like pull it really quick. I can't remember every meditation script that I've written. I can't. And every once in a while, sometimes, there's a really nice yoga nidra script that someone else has written that I love. And I want to use that one because it fits with whatever showed up on the mat that day. So I do have an iPad, and I use Evernote, and I have material in there, and it's all laid out. So, and it's broken out by, categories. It's essentially a virtual notebook, but I take that with me so that I can switch on a dime and not because when you're new, you get flustered. Like, okay, deer in the headlights. I have no idea what to do, which you can always breathe. That's usually a safe place to start. And will usually help you as well as the client.
Absolutely. Well, Kelli, I know you need to get on the road for a teaching assignment, and you've got a long drive. I feel like you've given us so much more than stroke. Looking at the variables and things to consider with stroke, you've done a beautiful job both online and in person, but you also helped us to understand how to get into hospitals and how creative that can be, and to, like you said, listen to the needs of the stakeholders.
Yeah, I mean, it's really huge. And it's not just hospitals. I'm going to say it's any program, it's any place that you want to step in the door. Like, I know our work is good. I know I mean, you and I are fairly involved in the yoga therapy community. We know people doing amazing work. And so I hate to say it's not enough. It's really, you have to assess the situation that you're going in and develop, just like you will with a client, a plan of care to how you're going to address those needs. And I would also say goals. And also the other thing too is revisit. Like, one of the things, and be prepared. Like, may have to do, I go through Joint Commission. Going through Joint Commission stinks. Like, if you've ever worked in a hospital system, like, there are alerts, like, Joint Commission is going to stand by it, is expected in the door. He's like, it will scare the scrubs off of anyone. But it's important to go back and revisit also with the stakeholders, like, hey, I know this is what we found, or if they need a specific measure, like I'll use the NeuroQL every once in a while because they want to measure. Sometimes they just want numbers, but you have to keep stats and things like that to show that to justify why you're there and
Right.
meeting their goals. So I think it's not really much different than you would with a client. You assess, you develop a plan of care, you deliver it, you reassess, you check your progress towards goals, you set new goals. I mean,
and that's just for the stakeholders, right? That's not even for the clients. That's the administration, right?
Yeah.
I have one student also that she about a year ago went and approached all these people locally. I'm a yoga therapist. I can do this, I can do that. And she got no bites. And then within a 3-month period, everybody came back and was like, we talked to you a year ago, but now we have different needs. We would like to hire you. And so she got like 3 or 4 really great gigs in 3 months because of the seeds she had planted a year earlier.
Yeah. I mean, planting seeds is a lot of what we do. Like, I always say in integrative medicine, it's like, 199 no's and one thing sticks, or you may, like, everyone's like, don't get excited. I was like, it's integrative medicine. I never get excited. Like, I'll pitch it over and over again, and I'll do all this extra work. And then the right thing will land when it's the right time. And, grants and things change, and money comes in that, has to be earmarked for a certain thing, or a grateful donor donated something for a specific purpose. And now you've planted that seed, and it's like, oh, that might work for us. So I think those are really important things to, don't.
Everything changed with COVID. There is more money coming down, right? It's good to recheck in and say, hey, we talked last year, but has anything changed? Could I come in for another cup of tea or take you out to lunch?
Well, and telehealth is, it's less, you don't need a physical space. So if there's things that can be met that way, that is more, from an administrative perspective, it is a little more cost effective. So it might be an interesting time to revisit it, especially like there's certain fields that we know are going to stay probably in like telehealth isn't going anywhere. Telehealth for yoga therapy is not going anywhere.
Right.
Your immunosuppressed clients probably will stay on telehealth because it's not safe to bring them into a large clinic with a ton of people going in and out, or, depending, what's going on with them. They don't need rides. If you or someone has a chronic condition that every time you have a doctor's appointment, a family member has to take off work, that yoga therapy probably will be one of the first things that drops off, because the oncologist or the neurologist is more important. The infusion is more important because they have to pick and choose. So these are ways that we can still access the client and is cost effective. So I think as much as I know there are some people that are like, I'm never doing telehealth. I don't think it's going to go away.
No. I think telehealth is the future of yoga therapy. Not that it can't also be done in person, but yoga therapy is so good for telehealth because, like you said, so many people can't get rides, don't want to drive, don't want to go out of their house, right? It's a perfect match.
And as a therapist, you don't need an expense. You don't have to rent a space. Like that is, having someone who's had I know you've had hard spaces. Having a storefront is expensive. And then you get into oh, I really can't, I've got to see X number of clients to just pay the bills. And that's not even talking about that's not even paying me a salary. Right. So I don't think it's going anywhere.
Yeah.
And I think we've learned that you can have connections we still can have really meaningful connections through the screen. And I know people are like, oh, it's got to be about touch. As someone who's licensed to touch, that I can feel like you can still show empathy. You can still make a strong, powerful connection. It's about showing up and being present and meeting the person where they are.
I think that's a great note to end on. Thank you so much, Kelly, for being with us here today. I feel like I took a bunch of notes as you were talking. I think all of our listeners gained so much from listening. So thank you for taking the time.
Anytime.
Thank you for listening to this episode with Kelli Bethel. And just to kind of recap a bit and give us some food for thought as we move into our week, how do we even define yoga therapy? What is the language we use to the people that we're trying to describe it to, right? That's the first thing. You have to figure that out. You have to figure out your 30-second elevator speech so that when somebody walks up to you and says, what do? You have something to say that accurately describes yoga therapy, but also meets the need of that person in front of you, whether it's a hospital administrator or a wellness clinic person or a PT or an OT. You have to have that down. And I think for a lot of us yoga therapists, we don't have that down yet. So that's your homework. That's your assignment. And I'm just going to suggest that you need to talk about the assessment in yoga therapy. That's one of the major differences between yoga and yoga therapy is there's an assessment, there's goal setting for the group or the individual or both, and there's tracking of progress towards those goals. And those are things people want to see. They want to see outcomes. One of the things that I have applied to teach at an upcoming conference is how to talk to providers about program evaluation. That I'm going to come in, here's what I think I can do for you. I have some little questionnaires I'll give everybody at the beginning of the 8 weeks, maybe in the middle and at the end, and I'll actually be able to show you program data, hardcore data, to see if the goals that we're setting are actually working. And, I could even include the healthcare provider in that discussion. What is it that you want to see? What data do you want me to collect? And then we can have the assessment. We both know what the goals are that we're working together on, and we have the data to support if that program evaluation is actually showing results. And that's very different than a peer-reviewed research project, right? This is kind of an in-house couple questionnaires, figure out the averages or the means and see if we got the results we think we did. And if not, we can revamp and try again. But having that data is so, so critical. And then the third thing that I think yoga therapy really needs to focus on is that we use all the tools in the yoga therapy toolbox. So we use the asana, the pranayama, the meditation, possibly sound, maybe visualization, maybe yoga nidra. But we're pairing up the initial evaluation that we did for the client or the group. Even within a group, we have individual mini assessments. And we're pairing that with the tool from the toolbox. We're not going in with a pre-planned class, as Kelly described. Somebody has a really emotional day as a person who's had a stroke, and their whole right side seizes up and they can't move. Your pre-planned script isn't going to work. Your pre-planned protocol isn't going to work. You have to be able to jump in and say, okay, well, if they had a really hard day and their whole right side is seized up, maybe we just do breathing today. Maybe we just do some visualization or some yoga nidra. And then maybe we can get up and do some postures. So, really showing that yoga therapy is going to meet the needs of the person in front of us and change as needed according to the assessment. We're going to track our progress. We have goals that we're setting, We can show data to show that, we've got those goals happening. And we're clear about the evidence-based research, and we can provide that when it's available. I'm just trying to think of the things you really need to be ready to talk about if you want to kind of get yourself in the door. I think that's a good summary to get you started. And then most important, the person who's in front of you, what are their needs? Listen, listen, listen. I always tell my yoga business students this. If you're going into a meeting, don't talk about yourself. Listen. Ask, what are your needs? What are the hospital's needs? How can I be of service to you? It's a very yogic idea, right? Instead of trying to tell them me, 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 say, hey, I want to know about you. I want to know what gaps you need filled. And then I'll tell you if I think I can fill those gaps. For example, everybody should be doing this gap where people are released from the hospital, but they're not quite ready to be out on their own. There's a business just waiting to sprout right there. And most hospitals, as Kelly said, don't want to send people out into the abyss with no support. They would be happy to refer to your business if you specialized in helping people bridge that gap from hospital release to total autonomy. And as Kelly said, those clients have stayed with her for 14 years. So it's not a 6-week thing. They get to know her, love her, and want to continue with her. So I think those are some really valuable homework ideas that I have for you. And if you can start to answer those questions and kind of follow along the path I just described, I think you're going to have a very successful yoga therapy business. All right, everybody, have a wonderful day. Thanks for listening. And if you can, go on Apple and give our podcast a review. That would be fantastic. Ideally, it would be positive, but if it's negative, we will take that into consideration. And we also have a private Facebook page called the Yoga Therapy Hour with Amy Wheeler. And we'd love to have you join that page. Thank you for listening to the Yoga Therapy Hour with Amy Wheeler podcast. Another nonprofit organization that we like to support through this podcast is the Krishnamacharya Yoga Mandram in Chennai, India. They are the source for the teachings of the Optimal State Yoga Therapy School, and we are so grateful. The KYM's Mitra division offers free yoga therapy training to a large number of socially and economically underprivileged children and women in Chennai. Feel free to support them through the link listed below on Red Circle, and we also have details on our website. And finally, a special thank you to our team here at Optimal State. We are truly a global family. George Mantuan, one of our executive producers. Adam Satchel, senior media producer and sound engineer from the Philippines. Krishna Panchal, a producer from Canada. Modupe Abdullahi, who does the show notes and is an editor for us from Nigeria. And Peter Morley, who wrote and produced the music for this show, who lives in Australia. Find more about Peter's work at www.zenmusic.biz. Thank you for listening, and we'll see you next time.